Okay, so welcome everybody to today's Family Medicine Grand Round Series. It is March 2nd, and the activity code for CME is listed there for you. If you are wanting to get CME credit for viewing this presentation, please be sure to make sure that you have registered with the CME office, and then you can text the number listed there, the toll-free number, and then from there you'll send your email address to that number, and then from there you'll text the code for today, the activity code. We have some further instructions on the next screen here, so I'll have you guys take a look at that. So here it shows more specifically, you text your email address to the toll-free number, and then once you've done that, you will text attend and then today's event code. Please make sure you do that before midnight tonight if you are wanting to claim credit. Next slide. This is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central Area AHEC, and then our department's mission statement is also shown there for you. Next slide. CME transcripts, if you are needing to view your transcript or if you have questions about your CME, please feel free to contact the CME website. Through their office, you can take a look at your transcript, but if you are having any questions, you're more than welcome to reach out to me as well. I'm happy to help. Next slide. Also, this presentation does award AAFP credit, so if you are interested and you are a member, please be sure to claim your credits. You'll need that CME transcript in order to do so, but if you have any issues, just let me know. Next slide. And we want to make sure that we do mention that it is the goal for all Family and Community Medicine Grand Rounds presentations to address the following nationally established physician core competencies that you can see listed there. Next slide. And Dr. Ferrer has no financial relationships with ineligible companies to disclose. Dr. Ferrer is going to be presenting for us today. He is the John M. Smith Professor and also the Vice Chair for Research in the Department of Family and Community Medicine. His topic today is the 5 A's of Social Determinants from the National Academies Report. So I'll let him get started.
Thanks, Nicole. And I'm happy to be with you all for a little while this early afternoon. We're going to talk about something that I spend a lot of time thinking about and trying to address. And I know you do too. And we'll talk about some of the principles that are necessary to achieve better outcomes in population health and healthcare. And that's addressing people's social circumstances that so deeply affect their ability to look after their health. So our objectives are, we're going to think about what are some considerations in doing what is being increasingly done around the country, which is to screen clinical populations for social needs, and hopefully get them connected with health. What's some emerging evidence from folks that are already doing it around the country? What are some people and partnerships that can help us either link or provide social care? Because obviously we're not in a position to ameliorate many of ameliorate many of people's social challenges. And then to the extent we have the time and the energy and the willpower, which I would advocate that we do, because we're witnesses to so much of the ill effects of social determinants, advocate for action on community level change. So I'm going to start with just a couple of words on social determinants. And I think of it in 3 ways. One, it's a mental model for understanding why people are sick or well. So, given what we've been learning for many decades now about the profound influence of social forces, certainly social determinants should be in our models of, besides all the pathophysiological models that we learn in medical school, these need to be in our logic models as well for why people are either thriving or not. In our everyday work as clinicians and the social folks that we partner with, it's an approach to caring for the whole person. So besides knowing that this person has a narrow problem, whether it's diabetes or hypertension or DJD, there's a lot of overlay from social circumstances that affect their ability to put the things that we're talking about into practice, to take their medicines correctly, to eat well, to get sufficient physical activity, or lower their stress levels and all that. And then there's a third sphere, which really everyone in our society should be part of, and that's an agenda for community action. They're called social determinants because we don't make them up one by one as individual people. We respond to opportunities and challenges in our environment because that's what we're stuck with, that's where we live. And so as voters, as community members, and then our policymakers, our politicians, our public health folks, our social organizations should be part of that equation as well. This is just a conceptual model. I'm not going to spend a lot of time on it, but this keeps the social and social determinants. As I'm going to talk about today, one of the risks in healthcare is that we devolve social determinants to just problems of individual people, and that's sort of that's where they end up. But they start in the way that our society is organized, the way that we allocate money, that we allocate education, that we allocate jobs, and all the policies underneath those allocations. So people's socioeconomic position, which in other words, their income, their standard of living, has a lot to do with the social class they grew up in, the influences of gender, of ethnicity, and there are a lot of times we're talking about racism in the operations of our society, and then what education, occupation, and income people can attain. And all those things sort of structure them a set of material circumstances, right? How well they can eat, what kind of job prospects they have and how that job treats them, what their neighborhood looks like and how easy it is to go out and just take a walk, get some low-cost physical activity. And the stresses, either very high levels of ongoing stress or manageable levels of ongoing stress. And all those things bubble down into our physiology to keep us alive or well over the many years. So I just wanted to situate us with that model. We're going to be operating at a much lower level of the model, which is going to be sort of the day of the level of practice and what we do as clinicians. So just a bit of vocabulary for us to get that started. The social determinants, again, these are high level things. So the conditions in which people are born, grow, live, and age. And it's shaped by the distribution of money, power, and resources, right? So those are very high level societal factors that, other than as voters and as community members who advocate, we may not have a lot of control over. When we talk about social determinants, I'm gonna ask that we, in our daily work in the clinic, we don't talk about addressing social determinants per se, because that's not what we're doing. We're not policymakers. We're not creating new sources of low-income housing. Sometimes our health systems are increasingly doing that in locations around the country, but we're not doing it. So the term I prefer for that, and a lot of people are preferring for that to keep things straight, is called social needs. So when our patients come to the clinic and they say, "Doc, my refrigerator is empty," that's food insecurity, and that's a social need. Some people also broaden that and say, use the term social risk factors. And again, those are person level circumstances, such as low income or housing instability that can undermine your health. So given that our healthcare systems, at least in our patient care roles, we tend to address social needs, not social determinants. So just a little bit of vocabulary savvy for us. I'm not going to spend too much on the statistics of social determinants because today is about what we do in our professional roles, but I just want to say a couple things to set the stage and to show you the power of them. These are data that Raj Chetty, who was at the time an economist at Stanford, I think Harvard has hired him since then. He did a remarkable series of studies where he got his hands on literally hundreds of millions of both death certificates and income tax returns, and he merged them so that he could look at people's personal income levels over time and their life expectancy, because he had their death certificates. And this is a graph showing each individual income percentile from the first percentile to the 99th percentile of income in the United States for women and men. And you can see this is the kind of graph we don't see a lot in biology. This is the kind of graph we see in physics, right? Where mass equals acceleration equals, sorry, speed equals acceleration times mass. So most things in health are more noisy, the relationships, but this is like physics. The 99th percentile of women and men live longer than the 98th percentile, which lives longer than the 97th percentile. And that goes all the way down to the bottom. So it really is a powerful influence on our longevity, and it has to do with a lot of the health conditions that that determine longevity. Now, we're not just in social strata by income. There's a lot of racial and ethnic considerations, obviously, in our society. And so this is, again, Dr. Chetty with that same data set, looking at what are children's prospects with parents at the same income level? Do they have the same outcomes if they're Black and white? And as we suspect, the answer is no. So he followed about 20 million children, which was 94% of the kids born between 1978 and 1983. And what he found was that white children born to parents at the 25th income percentile, on average, do what most of us hope our kids do, which is to do better than we did. They reached the 45th income percentile on average. And Hispanic children actually did almost as well, reaching the 43rd percentile if they're born at the top quartile, the bottom quartile. Asian children on average get to the 56th percentile, but only in first generation immigrant families. Otherwise, there's only a 2 percentile difference from whites once the family has been here for multiple generations. Now, much different story for Black and Native American children. Their incomes are shifted down 13 percentiles relative to whites, even if the kids were born in a top 1% family. And that's, the kids going through life and experiencing all those sort of racist institutions impact on their ability to go ahead. Also, this happens even at the top of the income scale for Black children. So if you're a Black child born to parents in the top 25%, you're as likely to fall into the bottom quintile as to remain in the top. Whereas white children are 5 times as likely to remain in that top quintile. So again, those are all the stats like that I'm going to show you, but I wanted to remind us of the power of social determinants for structuring people's lives and their life prospects, literally from the earliest ages. So before the National Academy report that I'm going to summarize today, there was an earlier set of meetings in National Academy reports, and the CMS, the folks who run Medicaid and Medicare, had asked them to do that, to think about what does a system of care for socially at-risk populations look like. And in one of those reports, which I had the chance to participate in, the bedrock of it is the system. The people in it have to care about health equity. They have to be thinking, what are the unfairnesses? What are the inequities? What are the barriers? We always have to think of the way our systems operate with that consideration in mind. So we have open eyes and open minds about what could be done. And then the next thing, as for so many issues, is to understand the data and the measurement. What are the extent of the inequalities, the disparities? What are the patterns that we see in people accessing or not accessing care, and in the outcomes they do or don't achieve as a result of accessing care? After that follows a comprehensive need assessment. So if we're going to help the patients that pass through our hallways, how do we identify the people at risk? How do we anticipate what they might need? And how do we create either programs for ourselves or linkages with other folks who can help them address their life circumstances? Once we've done that assessment, then we create partnerships, referral systems, hopefully with as the least friction possible, right? Because these are folks often with many challenges and transportation, not a lot of free time, because they may be working multiple jobs, not great childcare. So we need to think about the friction in those partnerships and how to minimize it. Care continuity is always good, just as we value care continuity in clinical medicine. It's nice to have a social worker or someone at the housing authority who knows you already, so you don't have to start your story from scratch every time. And so how do we set those systems up so that it's as seamless as possible? And then, as in, again, as in all the interventions we do in primary care, we need to engage our patients. So think about what is a given patient's trajectory to well-being, to lifting themselves up. And that's the cycle. So the report I'm going to focus on today is a report that was commissioned by the folks at Medicare and Medicaid, at the Center for Medicare and Medicaid Services, because they were embarking in some very ambitious demonstration projects around the country that I'll talk about, to look at what is the effect of these social factors on people who are repeat utilizers of expensive healthcare, hospitalizations, ER visits. And when people experience those adverse health events, what help can we invoke to make sure it doesn't happen again, or to minimize the chances that it does? And so the committee got together and identified 5 different kinds of activities. So one is awareness, and that's the very basic thing, right? If we don't identify patient social risks, we can't do anything about them. So now that sounds easy, but it's complicated. How do we ask? Where do we store the information? How do we update it? Some of the things we'll go through as we move ahead in the presentation. Once we're aware, how do we adjust what we do to account for those social risks? So, and I'll give examples of that as we go ahead. Because again, we want to make sure that our care is as responsive as possible to people's practical everyday experience. We can't be recommending interventions or new behaviors that are literally almost impossible for people to adopt. Now, you're thinking, that's a lot to ask of us. Yes, it is. That's why we need help, right? So the assistance is connecting patients with resources, whether it be the housing authority, the food bank, the social worker, behavioral health, the resources that they need to address the challenges that we identify. Now, potentially, we could stop there, and that would take care of our own house and get that in order. But it's nice to dream a little bit beyond that. So, what does alignment look like? How could health systems, who are usually not poor, some of the most resource-rich, depending on the health system that you work in. I'm talking about something very large at this point, like a hospital or a very large health system, not a solo family doctor clinic. What would an investment in community resources that address social risks look like? Some very progressive large health centers around the country, or like Hopkins in Baltimore, is actually investing in affordable community housing for their neighborhood, because they see that lead and bad water and all kinds of things. They see kids come in with those downstream events, and they know that they're preventable, and it's better to prevent lead poisoning than to treat it, obviously. And then the last thing is advocacy. And again, in the role that we play as witnesses to what community health challenges and the inequities, to the effect that those people have on the minds and bodies of people in our practices, we could be, and often are, effective advocates to make that case for what's necessary. So just some examples: awareness of social risks. Does the family experience food insecurity? An adjustment of our care would say, knowing that if you look at large hospitalization data sets, you can see that for people at low income, their hospitalization rates for hypoglycemia go up at the end of the month. And the reason that happens is they run out of food, they stay on the insulin dose that we took them to take faithfully every day, and their sugars drop down. They have to go to the ER for treatment. If we know that, we could say, if you find that your refrigerator is empty and you're not eating as much, reduce your insulin by a certain percentage and keep out of trouble. We can assist patients by changing their by changing their social context, and that's potentially having programs that the clinic links to that connects people with either food. We've done some pilot projects, as you know, with the food bank, or jobs programs that can help people get trained. And we could potentially be the portal, not that we're doing those things, but we're a portal that helps people access those resources. And then, alignment in, again, these are things not necessarily that we would do, but public housing could plant some community gardens to help people with food insecurity get a, not like HEB scale, but some fruits and vegetables to help them eat healthier on a smaller scale. And then being witnesses of the health impacts of food insecurity, we could be advocates to try and assemble new resources in that community. Social challenges have a pathophysiology, if you will, that we should try and understand. How people, for example, here's a list of coping with food insecurity. People, healthy food can be, doesn't have to be more expensive, but can be. People skip meals or cut the size of meals. Conversely, when they get a paycheck and the refrigerator is empty, then it's a good time to go to HEB, fill up the fridge, and maybe they binge for a couple of days to make up for lost time. This is not a bad coping strategy to avoid food waste. People will eat stuff till it's gone. On the other hand, if you're obese or hyperglycemic, that's not a great strategy for your disease control. People will eat low quality food. Stuff that's by its sell by date or past it can be cheaper in markets. And so, or if it's in your refrigerator and then it passes its sell by date, you hate to throw something in the trash that you paid good money for. People will seek additional employment, either formally or informally, make trade-offs in education, the kinds of schools they could send their kids to. People will reduce their medication consumption to stretch out those medications so they can buy food before they have to pay a pharmacy bill again. And obviously it reduces their prospects for paying transportation and rent. So people buy damaged products because they're cheaper. They rely on like 4 for $4 menu. Moms will often skimp on food to feed their children. And then probably not so much hunting in San Antonio, but in rural areas, often that's a coping strategy. So these are some screening tool examples that were identified in the reports. The National Academy of Medicine, Medicare and Medicaid, and the AAFP have all adopted kind of a 5-sphere screener: housing, food insecurity, utilities, transportation, and intimate partner violence or personal safety. There are some more extensive ones, sorry. Prepare is widely disseminated. It goes into things like stress and social connectedness. Now, before, again, one important thing to remember about screening is when we offer to screen someone, we're making either a covert or an overt promise that if we detect something, we can help you. Right? The ethics of screening are different from the ethics of sick care, because in sick care, the person comes to us. When we're screening someone, we're going to them and saying, I'm going to ask you questions, and hopefully I can promise some help for you based on what you tell me. So some of these items in clinical care may be hard for us to offer help for in the short term, like stress, people's social connectedness, health insurance. Often, we're not in a position to provide that unless we're providing free care. So as you think about adopting different tools, think about your ability to deliver on the implied promise of asking the question. And then Health Leads is it's a nonprofit that's been very active in the social needs space. So these are just some examples. I'm going to walk you through the CMS Screener. And some of you may have seen it already, but it's just a quick checklist of questions. What's your housing situation today? I'm unhoused, I have housing, but it's kind of iffy at the moment how long I can keep it. I have housing. They ask about the conditions in your house: mold, lead paint, water leaks, non-working smoke detectors, etc. Food insecurity is in there. So these are usually the 2 food insecurity questions. In the last year, did you worry that your food would run out? Or within the past 12 months, did the food just not last and you didn't have money to get more? Transportation needs: has lack of transportation kept you from medical appointments, meetings, work, or things, sort of activities of daily life? There's a medical question, obviously, that we're interested in, and people being able to get to us, like a more general question. Utilities are important, so there's a question about electric, gas, oil, water, Has the water, are they threatened shut off, or have you already had shut offs in the last year? And then finally, a question about, usually these are about intimate partner violence. Often does anyone, including family, physically hurt you? So that gives you a flavor for the kinds of things that we're concerned in social risk factors. And here are some of the social needs screening considerations. So if a patient's coming to the clinic, who is doing this? Do we have them do it in the waiting room? Can they do it on Epic potentially before they come see us? Do we do it once they're room? Do we do all of the above, depending on who's internet connected and who isn't? And exactly whose responsibility is it to make sure that it got done? Now we're going to hopefully intervene and send people to referral resources, and so we don't rework the same problem over and over. How do we keep the health record up to date? Into yes, this person's been to the food bank, this person's been to the housing authority, and so that's easy to find in a short visit. And then hopefully, what we'd like to do is track the social referrals and their outcomes. So yes, the patient had food insecurity, but that's resolved after the following measures, or yes, this person was a couple of months from being evicted, but they were on a new payment plan, or they're receiving some housing aid for low-income folks, and that's not the case, at least for for the last 3 months, and potentially they'll be on it for another 3 months, and so we can not worry about it until then. And then this is all local, so all the things that we would put together, for example, if you think about what a program to treat kids with allergy shots would look like in different cities, it's going to look more or less the same, the connections that you would need to make that happen. But every city has its own ecosystem of social services, and its own ecosystem of just how bad things are in different neighborhoods. And so everything's got to be adapted to local needs and resources by savvy folks. Now, the USPSTF, the United States Preventive Services Task Force, likes to weigh in on screening. And last year, they took up social need screening. They're not done, so they have an issue, but they usually do, which is an A, B, C, D, F recommendation on, yes, we should do this. The initial reports were these are important things to think about as we move through planning, screening, and evaluating it. So, at the patient level, there are challenges. There's a lot of stigma in asking these questions. People may not want to share that their circumstances are dire. They may be ashamed of things that are going on in their household or their trajectories. So there has to be a lot of trust that we build around this process. It has to be, again, as always, secure. It has to be confidential. And it would be nice at the front end, in whatever patient population we're wanting to evolve in this, to get a lot of user input at the beginning. How should we ask you these questions? Where should we store the results? How would you like us to follow through at future visits? What do the logistics of that look like? To make sure that what we do is as responsible and as respectful to their conditions as possible. As a clinician, we may wonder, well, okay, we've detected this. What are my referral resources? So we want easy access. In the best case scenario, and this is potentially possible, Epic has ways to link a referral directly to a receptor site. I don't know that those are turned on for us yet, but they could be with the right conversations and the right incentives and the right champions. At a health system, how do we use the data? Because obviously, at a health system level, we're not just thinking about the patient in front of us, we're thinking about our population of 2,500 patients with food insecurity. What could we be doing better to meet their needs, to make our care responsive, to link our care with partners who can help us? Is that kind of health system thing, does that depend on the grant, or does the health system want to actually put sustainable money into that, realizing that it's going to be hopefully a sustainable uptick in patients' health prospects? And then at the community level, if every health system starts doing this in town, what's going to happen to the food capacity at the food bank or the housing authority, or all the partners that we line up? Are they going to say, please turn off the tap for a little while because you're overwhelming us? So we've got to think through volume and connectedness issues. Now, what do patients think about social needs screening, right? Again, we need to understand how they view it, and there's some emerging evidence on this. This was a survey done in kind of community health center environments, 969 patients, some from ERs too in 9 states, so reasonably representative. 79% of the patients who responded said that screening was very or somewhat appropriate, 14% were neutral, and 7% reported inappropriate. So it's not too bad. We have a large plurality of patients who think this is not out of bounds for us to be asking about. But again, not everyone feels that way. So we could ask patients permission before doing this, or explain what we're going to do and see how aligned they are with the effort. All right, so we're already doing a lot of screening and a lot of assessments in primary care. You all know that very well from your clinic sessions and what you do afterwards in Epic to catch up. What is the effect on visit length to start with? This is a study, very recent, using an 11-question Epic compatible paper questionnaire that looked at the things that we just talked about. About half, obviously this depends where you do it. In an affluent neighborhood clinic, it's going to be much lower prevalence, except for maybe intimate partner violence, which cuts across. But half the patients in these clinics identified at least one social need, the most common being stress, physical activity, presumably doing that safely or often. There's lower alcohol and social connections. So you can see this was a questionnaire that was a little bit more clinical because they were thinking about health behaviors rather than social behaviors. It only added 1.7 minutes to the visit without screening. And that's just asking the questions, but that's not doing something about it. The other issue is if we ask the questions and the patient says, yes, I have this challenge, how many of them actually want help with it? And that depends on the problem that you're asking about. Again, in a reasonably recent study, 6% of those with substance abuse wanted help, which is perhaps not surprising. It takes a lot of effort sometimes to get people to the place where they want help. And again, not surprising also, 100% of people with safety concerns where they're potentially living, terrorized from a household partner day after day would like something done about that. A lot of unresolved questions still. A lot of these needs aren't static. They change over time. People might have temporary jobs for 3 to 6 months and they do okay. They pay the rent, they put food in the fridge, and then that temp job is over. Or a pandemic arrives and hundreds of thousands of people suddenly find themselves in dire, unforeseen circumstances. So we need a way to track. Once we solve food insecurity, let's say, we need to circle back, right, in 3 to 6 months and say, is that still the case that you're okay, or do we need to help you again? How's your housing situation, and so on. Most of the time, these things don't happen singly. There aren't too many people who live in a mansion or food insecure, or vice versa, eat extremely well, right? And but yet are on the verge of being kicked out of their apartment. So if you look at food and utility costs, housing insecurity, those things, just those two things are 60% correlated. So the challenge is often meeting multiple needs rather than just one thing. And hopefully being able to do that so that we're not sending a person to 6 different agencies to solve 6 different problems, because they don't have the time to do that, just like you and I probably wouldn't if we were asked to do the same thing. Most of the screeners we're already being quite ambitious, but they still miss something. So childcare is often a huge factor in people's lives, and few, if any of them, ask about that. And another thing is, do you have a financial issue for unexpected expenses? And then there's some bias about when and how we ask. So if we're doing a transportation survey in the waiting room of our clinic, we're missing all the people who couldn't come to our clinic because they didn't have a way to get there. Now, does it matter if we address these things? And there's some emerging evidence that it does. This is again extremely recent because these demonstration projects are just going on. So this is from what, 2 weeks ago. This is again, addressing those 5 items on the CMS screening, and they showed that if they did something among people with one visit, who had the, sorry, among people with one risk factor, there was double the risk of a repeat ER visit and coming back. And if people had 4 needs, there was 10 times the rate of them coming back for 2 or more ER visits. So there's a lot of healthcare use and a lot of human suffering as a result of these risk factors, and that's why it's imperative that we try to do what we can. Now, so that's assessment. Alignment means having a ready and willing social care workforce to take up the reins once we hand them off. And that's diverse. It can be community health workers, as we in our clinic make a fantastic use of, our promotores. It can be social workers, it can be home health, home aides, case managers, legal aid. And one common problem, as I mentioned before, is that you don't want to necessarily identify 5 problems and send people to 5 different offices. And so there are some emerging models, even in our community, that I'll talk about more efficient and effective ways to do it. So again, historically, community care coordination for, let's say, a 3-generation family, made up on this slide. You have the grandmother, Mrs. Garcia, who's older, who's in a Medicaid health plan. You have the mother, Marisol, who you can see is pregnant. And so she's getting Medicaid as a result of the pregnancy. And then you have the son, who's already out of the womb, Marcus, who's got chronic asthma and has been to 6 ER visits for asthma in the last year. And because of that, at one of his last ER visits, someone referred the family to Child Protective Services to make sure that Marcus got the kind of asthma care he deserved, and also perhaps that the family was in a house free of allergens and irritants that would set him off. So now you're looking at coordinators coming from the Children's Hospital, potentially from Child Protective Services, Medicaid managed care organizations have that. The health plan sometimes has that. And so they're going to keep that family very busy, often with duplicative and overlapping services, and that's not optimal for the family or the agency. So around the country, there's a new model called the Pathways Hub. And that means that you're doing it sort of at the family level. You have one caseworker who's going to solve multiple problems, who's going to be the go-between between all those agencies. And it's going to be much more efficient and hopefully more effective, because it's more time effective for the families who are often quite busy. And a lot of it has to do with connecting with agencies who can send either caseworkers or community health workers to the home to do these things. And these are folks with local knowledge. They're accountable for clients' competing pathways, because I'll talk about in a minute a structure that pays the caseworkers or the community health workers organizations for good outcomes. And it's organized in an information system. So we know who's making progress on their pathways and who isn't. And who pays for all this? You say, well, there's a logical entity. And I just showed you the outcomes that people end up in the ER 2 times at the low end or 10 times at the high end of challenges with enormous costs. Medicaid will pay for that because they're on the hook when Marcus ends up in the emergency room 6 times in 1 year. They're paying the cost. So one coordinator who's working with a set of different agencies, and they use checklists and sort of standardized ways of making sure all the things that have to happen, those are called pathways, but they actually do happen. And when the pathways are completed, then the family is discharged, at least for them, from the care management. The hubs have 20 core pathways that go everywhere from adult education to smoking cessation to housing to postpartum services. And the beauty of it is it closes the feedback loop. So the same person, Medicaid, or the same entity, Medicaid, that's at risk for paying out the costs of these bad outcomes, they can invest upfront on a much cheaper investment, which is a community health worker who goes into the home and does the services. And community health workers are very cost effective. 1 or 2 ER visits will more than pay the salary of a community health worker. We have a new hub in San Antonio. This is a map. They're emerging throughout the country because these social problems are big issues throughout the country. And so the hub is still expanding locally. Okay, in now this is what it looks like: 10 care coordination agencies, about 2,400 families served, which is not trivial, but in a city of 2 million people also needs a lot of growth. Our homegrown version, as I already talked about, is our nosotros program in the clinic, which what a care coordinator might do in a hub, a community health worker will do in a nosotros program, and beyond. Working with people more intensively than the case, much more intensively than a caseworker would to achieve the outcomes that we want. And the outcomes are very good. You've probably seen these graphs from Dr. Persani, but our community health workers have people with type 2 diabetes, have their blood sugars on downhill trajectories for 3 years plus, who do cut ER visits and hospitalizations in half. We have those statistics as well among the affected people. And it's been very successful. So I just want to close by saying these are the models, and we need to diffuse as many of these as possible. If you end up going somewhere with not resources available to you, there are some that are available in every community in the country or close to it. If your house is on fire, you dial 911 and they dispatch paramedics and the fire department to your house. If you're about to lose your apartment, you can dial 211 and everywhere in the country. It's authorized by the FCC for social services direct information. They'll connect you with the local housing authority and things go from there. Obviously, what happens after that is not tracked or organized necessarily, but it's a starting place. You may have heard of Aunt Bertha, which is sort of an equivalent that a lot of health services systems use to connect people with services. They recently rebranded themselves as findhelp.org. I guess it seemed like, who's Aunt Bertha? Let's make it more concrete. If you go to findhelp.org and you search, for example, help pay for housing, you'll get a screen like this. It'll show you who the entities are in your area, because it's geo-indexed depending on where you're calling from. Connect you with either a phone number or a website, tell you where it is. And then again, as a family, you're kind of on your own after that, but at least you go from knowing nothing and being desperate for help to having a direction to go into. There's a lot of for-profit entities getting into this space, and I'm not sure how that's going to play out. As you can see, the companies are worth about $18.5 billion for now. In the best case, it becomes what we do in America, which is monetize something, and then it happens much more than it used to. But again, the mix between social services and profit taking is yet unclear, so we'll reserve judgment. And then I'll close by saying this seems like a lot, but a lot of the things that we do in primary care, a lot of the burnout we experience is the inability to solve problems. So people keep coming back with the same challenges and putting into practice all the helpful things we're trying to arrange for them. So support in that endeavor is very welcome. And there's emerging evidence that it's also quite effective. We just need to think about doing that clinic by clinic, community by community in a way that makes sense and is fundable. So we ourselves can either solve the health problems, the health challenges faced by our patients, nor can we ignore them. I'll stop there, and we have a few minutes for discussion and questions. Thank you.
Dr. Ferrer, can y'all hear me?
I hear you.
Okay, thank you for the presentation. I think it's a very important topic. I just had like two, I guess, points, not really questions, but just points of discussion or points to ponder, if you will. I feel like one thing that I've noticed in the past, I guess more like since becoming like a medical student and like having people ask me random medical questions even before, residency, I've realized, especially in the African-American community, one of the, I would call it a social determinant of health is like the distrust of healthcare providers because of things like Tuskegee and just historic factors like that. There's other things for other ethnicities, but obviously I have the most experience personally with, like grandparents, older church members who were young children and young adults when Tuskegee was just being, found out. And so that obviously really tailored or colored their view of the healthcare system. And so things like that, I think also present a barrier, because those are kind of like what I've noticed that I didn't before practicing, is that those are like kind of like very generational, like uh, concepts that are passed down. I feel like, obviously I grew up, well, I mean, I think becoming a physician and going to medical school, I seeing the inner workings of the healthcare system. I see the imperfections and I see, all kind of both sides. But if I hadn't, I would probably still have some residual, like generational, like distrust, like, oh, does the doctor really care about what I'm saying? Do they even believe my pain? There's been a lot of studies showing that there's a lot of implicit bias when it comes to like African Americans' ability to tolerate pain and things like that. So I'm just saying all that to say that in addition to the SES and the housing and food insecurity and all of those factors, I also think we should just keep in mind the distrust. And I think that might be a little easier now, given like a lot of people were very hesitant about the vaccines. And I think now, obviously it goes beyond African Americans. It's like a generalized distrust of the healthcare system, which I think is like a whole other different topic. But germane to this topic is just keeping in mind that there might be some generational influences when it comes to having like a general distrust of the doctor, and that affects adherence and things as well. And then the second little point I was going to make is that I do appreciate that you mentioned some of the resources that we can glean from, because it can be overwhelming, especially like initially starting. I had no idea where to begin to show my patients like about like I had a patient who had like a housing issue. I didn't even know like we could contact the housing authority or anything like that. But that's what residency is for. And it's very important wherever you are to learn what resources are available by like talking with some of your patients, people in the community. I think church is another community helpful resource that lets us know if things are going on. And so I just wanted to kind of reiterate that point, because I think, like you said, like we get burnt, don't have all the answers, but sometimes slowly gathering up those little resources and things like that, I think have been tremendously helpful for me at least.
Yeah, thanks, Jasmine. Incredibly important point. The whole pandemic has been a big lesson in trust. And I think that's why, the way to achieve trust is with engagement with community. So in the best case, through mechanisms like our patient advisory council, at all levels, but we have one for the clinic too. And then we might convene just some small focus groups of patients, of users, and come to our clinic and say, what would feel right and look right and be most accessible to you as we embark on these kinds of screening endeavors? How should we ask the questions? How should we connect you with resources? What would make sense for you? Because in any endeavor, it's the most respectful thing you can do, obviously, is want to hear people and understand what they think and act on it. And so that's our responsibility going in, is to make sure we do that in an authentic and effective way.
Hey, Bob, if I could just pick up on that point just a little. So you've talked about a number of social determinants of health that we can quantify, or at least semi-quantify, food, income, that sort of thing. But when you're talking about the trust issue, that sounds harder to quantify, so that I think we can all agree there's a big issue there. But how do you measure, how do you tell you're getting better or worse if you can't measure it?
Well, the social scientists are good at creating all kinds of measures. And I'm sure there are measures for trust in your healthcare provider or your healthcare system. I'm sure there are measures like that out there, because I know people are using them. So again, the one that we might think about if we wanted to do that would be to see what the different measures are. Maybe get a few patients together or a PFAC and say, well, how does this look like to you? Is the language the same way that you think about trust? Is it congruent with that, or are we missing some ideas that you wish we would also ask you about when we surveyed folks?
If there's not another question, Bob, I'd just like to make one more comment, and that is, I don't pretend that we're doing everything right here, but we're doing a lot. And so I just, a lot of the residents and others here that at some point they're going to work in other systems or at other places. And so just to encourage people to keep in mind for the future, not every place has as much as we have here. So that's certainly an area that you can work on for improving the patient care at your next location as well.
Yes, good point. So because of, I think two things. One is because it's a teaching practice. And the other key thing is the mix of people we have in our program who really care about these issues. And I think we're relatively rich in that. We have done a lot of assessments of, we did our transportation study. We've done assessments of food insecurity. We've done assessments of other life spheres. And we followed that up by convening a very effective and resourceful community health worker program that's been doing amazing things that aren't available in a lot of areas, and that we depend on to carry forward these our patients with social needs on multiple spheres, not just their blood sugar, but they think a lot about social determinants, that the promotores do, and how people are doing on those key factors. So we're in a relatively resource-rich environment for those issues here, and still, we'd always like to do better.
I did have a question come in directly to me, Dr. Ferrer. It's saying that the limited time allotted for appointments challenges family physicians to perform these screenings. So how can a care team effectively screen for social determinants of health and maximize the efficient use of the physician's time?
Right. So again, like any other new procedure, each clinic has to adopt a workflow, test it, and see who has time to do this, who is the logical person to do this, and how can we make it most efficient so that we're not missing people, but at the same time, we get through the day, because the number of screenings that we're asked to do in primary care is now quite high, as we all know. And but I mean, I would argue that the social needs screening can have as much effect, if not more, on many of our patients' health outcomes as the other things that we screen for. So we need to be judicious. We need to listen to all the people in the workflow about how it would affect their daily routine and compete with other things they're already doing. But I think enough healthcare systems are doing it now that there are helpful lessons out there. But the talking and we just can't drop a bomb on everyone and say we start next Tuesday. We've got to think about everyone in the organization and how it makes sense, what would make sense for them.
Thank you. Do we have any other comments or questions for Dr. Ferrer? Okay, well, with that, I will go ahead and I do want to remind everybody that the evaluation link is in the chat box there. If you could please provide feedback for us on Dr. Ferrer's presentation today. But I want to thank everybody for joining us, and thank you so much, Dr. Ferrer, for your presentation today.
No, thanks to everyone for being here. Appreciate it.